It is with great pride that Planet serves as the digital partner for this event, hosted by the Indian Society of Anesthesiologists, Pudukkottai City Branch. And the focus of today's session is spinal analgesia, technical difficulties. So let's begin today's session, for which I would like to invite Dr.A.L. Meenakshi sir, and I will take few moments of yours to introduce her. Dr. A.L. Meenakshi is a renowned anesthesiologist with an ABBS, BA, and MD. He has served as the administrator at Government Medical College in Thane, Chennai, and Standard, and as a professor of anesthesiology at Thanjavur and Tirunelveli Medical College. He is also a former National Vice President and Governing Council member 2009 to 12 of the Indian Society of Anesthesiology or ICA, and he also served as President 2011 to 12 and State Secretary 2006 to 10 of IASA Tamil Nadu. Welcome you, sir, and over to you. Kindly proceed with the session. Thank you so much.
Thank you, Clement. At the outset, I request ISA Pudukkottai City Branch President Dr. Munian to offer his presidential remarks.
Sir, good evening, sir. It's my honor to welcome you all for the online webinar conducted by the ISA Pudukkottai City Branch in the name of Puthukkottai Bhudhan. Our association represents the highest standard of anesthesia care, collective voice of specialty dedicated for promoting the highest standard of anesthesia care and education like our online webinar. Since we are the reputed anesthesiologist, we have to take utmost care for ensuring the safety and well-being of our patients during surgery and other medical procedures. Last week, we conducted an online webinar on the topic of thoracic surgery and lung resection by Medanda Medicity Kurugaram. 545 delegates were attended. Thanks to our academic chairman and my respected professor, Dr.A.L. Meenakshi sundaram sir. Today, on our online webinar conducted on the topic of spinal anesthesia and technical difficulties, which is the 8th episode of our second edition. Today our speakers will speak on the three categories. One is the anatomy and spine, anatomy of spine and anesthesiologist review by Dr.Hamed Ali, PG student, ESI Medical College, Hyderabad. Welcome, sir. On the second topic, troubleshooting in getting subarachnoid space by Dr. Shilpa Bhatt, Assistant Professor, Yenaboya Medical College, Mangalore. Welcome, madam. This is an elaborate topic. Madam will simplify the topics to the delegates and our PG students. And the third topic is UAG guided central neuroaxial blockade, which will be taken by the Viral Parekh, consultant, PD Hinduja Hospital Research Center, Kar, Mumbai. The whole session will be moderated by our respected State President, Dr. Kirupakaran sir. Welcome, sir. Spinal anesthesia and technical difficulties would likely delve into the challenges and complications associated with this type of pain management. Some of the technical difficulties that may be discussed in today's topics are difficulties in achieving optimal analgesia, which is commonly encountered in patients with a complex medical disease. Next is post-dural puncture headache. This is a common complication. Today we are seeing our day-to-day practice. Sometimes it may be difficult to manage. Sometimes they need multi-dimensional interventions. And the third topic is catheter-related issues. We are using spinal catheters in different sizes. The catheter may sometimes thin and leakage. So the inadequate spread of analgesia. So inadequate pain relief. That is day-to-day we encounter. Spinal anesthesia is a safe and effective procedure for various surgery. However, more studies are needed for safety and efficacy of the anesthesia, spinal anesthesia in different populations. We can overcome the difficulties by improving the training and educations, advancement in technology, and alternative methods like alternate method for we can use continuous epidural anesthesia instead of continuous spinal anesthesia, and multi-dimensional disciplinary collaboration. We can discuss with our different specialty surgeons. We can plan the anesthesia according to their need. So today we gather to our online webinar from the eminent speaker from various institutions, and they are also interested to share their experience with all of us. Let us work together to advance the field of anesthesia to improve our patient's outcome. Welcome, sir. Welcome. Thank you, sir.
Thank you, President. Now I request our Secretary, Dr. Kannan, to offer his remarks. Secretary.
Yes, sir. Sir.
Yes, sir. Are you
Sir.
Yeah,
voice is
breaking.
Am I audible, sir?
Audible. Can you please speak?
Good evening, all. I'm Dr. Karan, Secretary of Puthukkottai. Successfully, we are conducting 8th webinar of Scientific of Puthukkottai Bhudhan. For technical difficulties, our President Dr. Munian has given a brief explanation. I welcome all the remaining speakers. Last 5th March, our 7th webinar was conducted perfectly with the enthusiastic speakers. The 7th webinar topic was thoracic surgery under section. This is very much interesting and the special one. The subtopics are discussion on lobectomy and preoperative evaluation of patient posted for lung dissection and lung isolation and intraoperative management of lung dissection. Case discussion of lobectomy was done by Dr. He is in thoracic anesthesia, Vedanta Medicity, Gurgaon. He has given a detailed discussion of lobectomy, which was very much useful to exam postgraduates. He has explained the history taking, clinical examination, and complete anesthetic implications in lobectomy. And second one is preoperative evaluation of the patient post resection. Dinesh Kumar Singla, Associate Director, Vedanta Medicine, Gurgaon, given the clear ideas about the preoperative evaluation. Preoperative evaluation includes case history, clinical examination, and investigation with the different slides. He has elaborated all clinical.
Thank you, Dr. Kannan. I think you have some internet difficulties. So without any further delay, we have to move on to the next session. Kannan, thank you. You are having some internet problem. So as a thematic address, I want to say a few things. This is a second episode of Puthukkottai Bhudhan weekly webinar. Already we have conducted 52 episodes successfully a year back, and now we are in the 8th episode. Now this episode is drawing attention. It is special. It is important for the simple reason. Now this is pan-India. Now this is pan-India. So far, one institution was taking that. Now you see the postgraduate is from Hyderabad, Telangana. The second speaker, Dr. Shilpa, is from Karnataka. And the third speaker, Dr. Viral Parekh, is from Mumbai, that is northern segment. And it is moderated by a Tamil Nadu person, none other than Tamil Nadu president. So as a pan-Indian movie, Pudukkottai has projected pan-India. This should be a landmark that we are going ahead. And I think it will be always better if it is like this. So it is for the people also to meet. So far, when an institution offers, now we are happy. The institutions offered to help us. They want to serve the cause of academics. So till August, our slots are filled. This is something great. It was not possible in the first edition. So the second edition, we are very happy they are coming forward. And even I appeal to all the prospective speakers to come forward. If there is a gap, we will fill it from our side. So I thank for the Pan India. So the postgraduate Dr. Hamed, who is going to talk about anatomy of spine. He has graduated undergraduation from Deccan Institute of Medical Sciences, Hyderabad, and he was a vice president of a NGO organization, and now he is the president of the Resident Doctors Association, and everybody will perform as a anesthesiologist. We perform spinal puncture with hands, but this man will hit everyone with hands and legs because he is a volleyball player and a football player. So both things he can do, and he has represented even inter-university. He has represented inter-university. He has won medals, both basketball, volleyball, that is hand related, and football also. So I welcome, I thank Dr. Hamid for having accepted our offer. It will be followed by Dr. Shilpa Bhatt, who is a renowned speaker. She is from Ennapoya Medical College, Mangalore. She has pleasant manners, and she is having a ready-made smile, ever ready, with a green smile always on her face. It is very difficult to see an anesthesiologist like this. And she has performed very well in Patna National Conference. She has done specializations in regional anesthesia, and Madam is having so many extracurricular activities. Mainly, she is a treasurer of Mangalore City Branch. And see, because of her pleasant manners and polite behavior, she has been placed as a brand ambassador, that is social media propagator. You can call it in either way, for IJA, for GARG. So she has been placed like that, madam. Then she's a digital media enthusiastic. She's a crossword and IJA quiz creator. So she has everything. So we are happy to have a madam as our speaker, and it will be followed by Dr. Viral Parekh, who is from PD Hinduja Hospital, Mumbai, and he is qualified from BJ Medical College, and then acquired special qualifications from Seth and KEM Hospital. So he is a great scholar, and he is actively participating in Nizora, and he is an executive committee member of Mumbai Metro City Branch. Imagine the number of anesthesiologists there, and he has come as an executive committee member of Mumbai Metro Association. So it is having the large volume of anesthesiologists for any Metro City Branch. So he is one of the executive committee members, and he is a dedicated anesthesiologist and a dedicated speaker. Why I am saying that dedicated anesthesiologist and dedicated speaker? He knows nothing other than anesthesiology. That means he has devoted his life for that. He is not concentrating on any extracurricular activities because he is passionate about teaching. He is passionate about anesthesiology, and Hinduja Hospital, he is serving like anything. I think yesterday he was on duty. Continuously, he is on duty and working for Hinduja Hospital. That hospital is blessed to have a young man like this. And as usual, he is a handsome figure, like a Bollywood hero. So we want to have a good moderator. So a good moderator is none other than our president, Tamil Nadu ISA President Dr. Kirupakaran. He was a former secretary of Tamil Nadu City Branch. He is also having pleasant manners, and I have never seen him angry. Even he is becoming angry, nobody will notice that because his decibel is very slow. His decibel is in a low volume. So even if he shout that, nobody will listen to him. So it is a blessing for him. He's a very soft-spoken gentleman. At times he will not smile. Most of the time he will be smiling only. So at that particular point of time only, we know that he is upset with something. So, but he will not raise his decibel. So see, he is from Salem, Tamil Nadu, and he is also a football player, kabaddi player. He is a music lover. In addition to anesthesiology, he has gained special skills in diabetology and basic and advanced pain management and palliative care. See, he is having a dedicated pain clinic from 10 a.m. to 1 p.m. for the past 15 years. To serve that efficiently, he has never taken up any anesthesia cases between 10 to 1. He is a freelancer, but 10 to 1, he has dedicated his life for pain relief, that is anesthesiology. So we are very happy to have Dr. Kirupakaran as the moderator for this session. So now we hand over the session to Dr. Kirupakaran, moderator. Please take it over, sir.
Thank you, sir. Thank you, sir.
Sir, you go ahead. You can invite.
Yeah. Okay. Thank you. Good evening, all of you. I am very happy to participate this second edition of Puthukkottai Bhudhan, organized by respected Dr.A.L.M. sir and respected President of Pudukkottai City Branch, Secretary and Treasurer, and speakers of today's session. Good evening, all of you. Today's topic is very informative, and some people, they may feel it is a very basic topic, but it is not a easy topic, because many people, the surgeons, they say it is only a spinal anesthesia, but it is anesthesists only know what is the difficulties in giving spinal anesthesia, because many times they consider the spinal anesthesia as an alternative to general anesthesia, but it is not like that, because it is a blind technique. So far, we have been giving spinal anesthesia by landmark technique only. Many times we have faced the problems in giving spinal anesthesia. However senior you may be, when you don't get a spinal in a single shot, you will become a jittery. So you try to get a spinal as quick as possible before the surgeon notices, because that is the problem in getting spinal anesthesia, because it's a blind technique. But of late, we are very fortunate to have the latest technologies like ultrasound to throw light on our part of needle, part of spinal needle. So we are able to accurately give spinal anesthesia. Our topic today is about that only. We have a very eminent speakers from all three states. So let us not waste any of the time. We will go to the first topic today. The speaker, please. Hamed, please.
Good evening, everyone. Thank you so much, sir, for giving us such an opportunity. This is Dr. Hamed Ali, postgraduate resident at ESI Medical College, Hyderabad. So, our topic is anatomy of spine. So, as an anesthetist, we give maximally and routinely we give spinal anesthesia. So, for that, we should be thorough with the anatomy and physiology of spine as well as epidural space. So, coming to vertebral column, this vertebral column starts from craniocervical junction and it ends at the tip of coccyx. As we can see, we have 7 cervical vertebra, 12 thoracic vertebra, 5 lumbar vertebra, 5 fused sacral vertebra, and 4 fused coccygeal vertebra. It encloses vertebral canal through which spinal cord and its meninges and vascular structure passes. Its total length is 70 centimeters in male and 60 centimeters in females. The functions will be it supports the head, maintains body in upright position, protects the spinal cord and its nerve roots, acts like a shock absorber during physical exercises, mobility and stability to the trunk as well as extremities. So basically, at the time of birth, the baby will have only one primary curvature. As the time passes by, when the baby attains head balance, he'll have cervical lordosis. He has thoracic kyphosis and lumbar lordosis when he starts walking, and also primarily will have sacrococcygeal kyphosis. So coming to basic anatomy of a vertebra, typical vertebra, it consists of a body through which weight is transmitted, vertebral arch which surrounds and protects the spinal cord in the vertebral foramen. It consists of lamina, the pedicle, on the lamina will have a transverse process, a superior and inferior articular facets, which bear articular facets. Pedicles are notched on either side so that two adjacent pairs together form an intervertebral foramen through which emerges a spinal nerve and a spinous process. The anatomy of spinous process is important because the direction of spinous process will help us in guiding our needle during spinal or epidural anesthesia. Coming to cervical vertebra, it is a small, flat body with a large triangular vertebral foramen. It has a short transverse processes which have foramen transversarium. Through this foramen transversarium, vertebral arteries passes. The typical cervical spines are short and bifid. C1, first vertebra, is also called as atlas and it communicates with the occiput. Atlas doesn't have any body or any spine. Whereas C2 is axis, it has a long odontoid process called dens which helps in communicating for atlantoaxial joint. Vertebra C3 to C6 are similar, that is, they are typical vertebra. C6 vertebra has an anterior tubercle which is large and is also called as Chassagn's tubercle. The importance of this is on this tubercle we can palpate carotid artery. C7 has the most prominent spine and is one of the most prominent vertebra. There are totally 8 pairs of nerves. 7 pairs of nerve in the cervical region comes out above the vertebra, whereas C8 comes below the C7 vertebra and followed by each nerve will come from their respective vertebra from the lower side. Coming to thoracic vertebra, body is conventionally heart-shaped and bodies of T5 to T8 are flattened on the left side. This is because the pressure from the descending aorta. In the cases of aortic aneurysms, this is eroded. Vertebral foramen is circular with a smaller diameter. The lamina are broad and they overlap with each other from above down. The spines are long and angled caudally. That's why whenever we are putting a thoracic epidural, we have to place the needle in the slightly angulated, caudally angulated position. Lumbar vertebra, the body is large and kidney-shaped. Vertebral foramen is roughly triangular. The pedicles are thick with shallow superior notches. Transverse processes have accessory process and mammillary process. The laminae are short, broad, and strong, but they do not overlap with each other as we see that in thoracic region. And also the lumbar spines are horizontal or oblong. Whenever a patient is sitting straight, the lamina and spine may interdigitate with itself so that when we are trying for a spinal, we'll hit a bone. That bone, whatever we are hitting is the lamina. So at that time, what we can do is we can ask the patient to flex forward, increasing the gap between the lamina and spine. Coming to sacrum, it is fused by the 5 fused vertebra and is wedge-shaped. The anterior rami of sacral nerves transmits anterior sacral phenomena. Posterior rami of sacral nerve emerges from posterior sacral phenomena. Each articular crest terminates below in the sacral corner. There is a laminar arch which is fused by the vertebral arches and it is missing in the last side. So this forms a defect, that is sacral hiatus. The posterior sacral foramina are continuous with the epidural space in the sacral canal. So whenever a patient is having, we can give injections of small volumes of local anesthetics through these foramina, which will cause segmental unilateral transsacral nerve block. Coming to spinal cord, it acts as a relay station or as a processing center for the information for somatic receptors and relays it to the brain. It contains the spinal canal or vertebral canal, contains the spinal cord with its coverings, that is meninges. The meninges are pia mater, arachnoid membrane, and dura mater. Pia mater will be adherent with the spinal cord. Arachnoid matter will be adherent with the dura mater. And the space between arachnoid membrane and pia mater is filled with cerebrospinal fluid. This is the place where we deposit our local anesthetic at the time of spinal anesthesia. This spinal cord ends at the level of L1 in adults and L3 in children. The blood supply of the spinal cord is by one anterior spinal artery and two posterior spinal arteries. And it is also reinforced by the radicular arteries. as we can see, one radicular artery which is important for us, artery of Adam Quicks. This is the largest radicular artery, and this supplies nearly 2/3 of the lower spinal cord. Any thrombosis to this artery will lead to ischemia of the spinal cord. The conditions can be hypotension. If during aortic aneurysm repair surgery, at that time, if there is any block, this might lead to ischemia of spinal cord. So transverse section of spinal cord, we have gray matter and white matter. In white matter, we'll have ascending tracts and descending tracts, whereas gray matter is divided into lamina. There are total 9 laminas. The surface landmarks which are important to us, it is important because we should administer epidurals in the appropriate area for appropriate postoperative analgesia to the patient. The C2 is the first palpable vertebra. C7 is the most prominent cervical process. The inferior border of the scapula will correspond to the level of T7. The superior aspect of iliac crest, that is if an imaginary line is drawn between the highest point of both iliac crest, it will intersect with the body of L4 or the L4 alpha intervertebral space. So this is an important landmark when we try to give lumbar epidurals or spinal anesthesia. And the posterior superior iliac spine corresponds to S2. This is important when we try to block the posterior foramina of sacrum. So coming to subarachnoid anesthesia or spinal anesthesia, the boundaries will be posteriorly, it is bounded by a spinous process, a lamina. Laterally, it is bounded by transverse process or a pedicle and a pedicle. Anteriorly, it is bounded by vertebral artery. So whenever we try to give spinal anesthesia, what all structures will pass? First is skin, then subcutaneous tissue, then supraspinous ligament, interspinous ligament, ligamentum flavum, dura, and arachnoid membrane. Then we'll finally reach into the subarachnoid space. So conventionally, we'll go in the midline approach. But if any patient is not able to position him properly, like if he's having some fractures, or if in the old age the ligaments will be calcified, so in these patients we might need to try paramedian approach. In the paramedian approach, we'll bypass all the ligaments. The structures whatever we pierce are skin, subcutaneous tissue, paraspinous muscles, and ligamentum flavum. The epidural space, it is a potential space present between the ligamentum flavum and the dura mater. It extends from foramen magnum in the top to the sacral hiatus in the bottom. It is a segmented and not uniform in distribution. It is widest at L2 and narrowest at L5. The boundaries will be foramen magnum superiorly, that is cranially. Caudally will have sacrococcygeal ligament. Anteriorly will have posterior longitudinal ligament. Posteriorly will have ligamentum flavum and lamina. Laterally will have pedicles and intervertebral ligaments. So the contents of this space will be fat, areolar tissue, nerves, lymphatics, blood vessels, including Batson's venous plexus. The importance of this Batson's venous plexus is that it is a valveless venous plexus and it communicates from the pelvic veins to the cranial veins, and it will drain in the azygous vein. That is, azygous vein will drain into inferior vena cava. So if any patient is having any obstruction in the inferior vena cava, or in the pregnant patient, if the uterus is compressing the IVC, this blood will flow through these Batson's plexus and these veins will get engorged. So the epidural space is decreased and we have to reduce the anesthetic dose, whatever we are giving in epidural anesthetic. The width will be cervical 1 to 1.5 mm, upper thoracic 2.5 to 3 mm, lower thoracic 4 to 5 mm, and in lumbar 5 to 6 mm. So coming to caudal block, the dural sac terminates at the level of second sacral vertebra. Epidural space continues below this point and can be assessed via caudal or sacral hiatus. Pediatric anesthetists occasionally use this route of access to the epidural space to pass an epidural catheter into the lumbar or even thoracic region. Or also we can give directly caudal block with bolus dose of any drug. The technique of caudal block depends upon identifying the caudal hiatus. So it is basically the patient will be kept in a lateral position. The posterior superior iliac spines will be palpated and the caudal hiatus or sacral hiatus will be identified. This posterior superior iliac spine and the caudal hiatus will form an equilateral triangle. Once after we find this caudal hiatus with a 21 gauge hypodermic needle, we'll go into the space at an angle of 45 degrees. We'll penetrate the sacrococcygeal ligament and here we'll get giveaway. After we get a giveaway, the needle hub is depressed and we pass the ligament. And we'll aspirate and give the drug according to Armitage formula. If we have to confirm it, we can do Woosh test also. Thank you.
You can stop sharing your screen. The questions will be taken at the end of all pre-sessions. Now we will move on to the second topic by Dr. Shilpa. Over to Shilpa.
Thank you, sir. And thank you for that lovely introduction, sir. I'm smiling a little more than I usually do today. So I have a very interesting topic today, that is how to troubleshoot to reach the subarachnoid space. So Hamid has done a wonderful presentation and he's already made my job pretty simple. So I'll be taking it from here. It's easier for me. And I'll just be touching on some of the important aspects of the anatomy also, mainly the applied anatomy. So before I begin, I bring with me greetings from the place I work, that is Yenapaya Medical College, from the coastal town of Karnataka, that is Mangalore. So my talk will be regarding the fundamental concept, some amount of basic anatomy, more towards the applied anatomy, various approaches to reach the neuraxis, the aids to troubleshoot a difficult spinal, thoracic neuraxial anatomy and troubleshooting, considerations in special population, and some tips and tricks. So whenever we are called, when there is a difficult spinal, this is the visual you usually get. That is, a resident or a PG has tried and made a dartboard out of the back of the patient. So this is what we usually get to see. So if we actually look at the pricks here and how they are placed, we can understand that the person who is trying or the performer has not exactly understood how exactly to troubleshoot when the spinal is difficult. So the entry points are all within 1 square inch and all very close to each other. And they have not really understood how exactly you try to troubleshoot this. So let's try to learn how to troubleshoot a difficult spinal. So before directly jumping into troubleshooting or finding a solution, let's try to define what exactly is our problem. What is it that is making things difficult? So it could be the narrowed interspinous or interlaminar spaces, which could be because of difficult positioning, suboptimal positioning, or a degenerative spine, which is in case of elderly. It could also be because of difficult surface landmarks in case of prior surgeries or obesity, or distorted landmarks in case of scoliosis. So what exactly do we do, or how do we counter this? So in case of the first scenario, we go for better technique, you better the position, or use some alternate approaches to reach the midline. In the second scenario, when you have difficult surface landmarks or distorted landmarks, what you prefer is to take an aid of the ultrasound. So in my talk, I'll be basically dealing with everything that is technically needed to troubleshoot a spinal, and rest will be dealt by Viral. So in this study, Atal et al. And his colleagues tried to develop a difficulty score for spinal anesthesia. So they grouped the performers or the providers into two groups. That is a category of who is having experience between 6 months to 1 year, and group A, who is having experience of more than 15 years. The outcome variables which they saw were the number of attempts that was required to establish a successful block, the number of levels they had to prick so that they could get a successful blockade, and complications associated. So this was the scoring system. And what they concluded was the spinal bony landmarks and the radiological details of the lumbar vertebra are independent predictors of difficulty during spinal anesthesia. There's no difference between a senior or a junior providing the anesthetic care, and a grade of more than 4 in the difficulty score was supposed to be difficult. So this is another study by Prakash and his colleagues where they try to find the factors which could predict a difficult spinal block. So here they categorize the variables into patient related, the performer related, and the instrument, the needle related. So here they also looked into details like the distance of the cervical spine from C7 to the coccyx, the subarachnoid space depth, the good quality of the bony landmarks, and the absence of crowded spine. So they concluded that the first puncture success of the spinal block was influenced mainly by the patient's anatomical factors, whereas the number of attempts that was required to establish a successful blockade could be both because of provider and the patient-related factors. So where are we heading? So 90% of our practice, whenever we are trying to establish a central neuraxial blockade, we are mostly going for the midline approach. So 90% of the time, we are trying to access the midline. So is it really that easy to determine the true midline most of the times? So if we actually look into this, the spinous process is not always pointed. It could be bulbous, and the width could be anywhere from about 2 to 3 millimeters. So it's not exactly always pointed. And also the spinous process, it's also not always placed one below the other in a straight line. So if you look at the image here, if you're entering with the midline, then you are reaching our target, that is the interlaminar space. But if you're slightly paramedian, which is not in the correct angulation, then you could probably hit some bony areas like the lamina or the facet joints, and so and so. So here, what comes into picture is having a very good optimal positioning. So how to position a patient for spinal may be like, the flexion of the cervical area and the flexion of the hip. I'm not going into details of that. We already know that. But we need to understand that, see, in extension, the interlaminar space is not that great. So, but when we try to flex the spine, the space you have is better. So if we look at this scenario where the position has been good, and if you look at this image here, you can see that the patient is well positioned with good flexion, and the spine of the patient is parallel to the long axis of the table. So this is good positioning. And if I draw an axis that is perpendicular to the long axis of the table, this could be, my direction of entry to get a good subarachnoid block. So if you see radiologically, this is how you would enter when the positioning is good, and you will shoot into the interlaminar space. But, so this is how we have when we have a good positioning. So what happens when there is suboptimal positioning, or there is some amount of rotation, or we are not very happy with the position? So here, if I look at the same, the same axis, which is perpendicular to the long axis of the table, and try to enter the same way, then I will be hitting some bony targets at this point. So you have two options at this point. Either you correct the positioning and make the positioning better, or you consider the rotation of the spine that exists in this position, get the 3D anatomy of the spine in your mind, and then you see how do you angulate the needle so that you can reach the target. So you slightly change your direction of entry, and there you reach the target. So it's extremely important for us to get the fundamentals right, to have a 3D mental model of spine each time we go ahead with the spinal anesthetic. So for us, central neuraxial blockade is a core skill for all of us anesthetists. Whatever technical and difficulties we encounter during the process of establishing a good blockade, we dismiss it by calling it a blind procedure. So is it actually blind? So let's have a look at that. So if you look at the 3D mental model of spine, so just look at the video here. You can look at the angulations at the cervical area, the thoracic area, and the lumbar area. The thoracic area can further be divided into upper, mid, and lower. So at this point, if you see, the mid-thoracic area has the steepest angulation. The lower thoracic and lumbar is not very well angulated. It's somewhere around 15 degrees, and that could be easily managed. So if you look at the 3D video here, you get a better idea of what exactly you're targeting and what's the space that you have, and how do you need to redirect, and where do you need to enter to get a successful blockade. So this is something we do on a daily basis, but I need to stress on this, and I really need to reinforce this. The art of needling when it comes to subarachnoid block is very subtle. So the angles what you make, even the small change in angulations that you can make, could translate to a larger angulation when it comes to the tip of the needle. So the angulation you make to reach the space need to be very small. All the redirections have to be gradual, incremental, and controlled so that it could translate into the angulation that you need to navigate the space. So where exactly is the problem? So let's just look at the parts of the vertebra so that we could understand this better. So the part painted in yellow is our body, as we all know. These are the articular processes. Then you have the transverse process. What's projecting posteriorly is the spinous process, and then you have the lamina. So before we try to troubleshoot, we need to look at the spine in a way that we understand where are we standing right now and how do we change our path so that we could reach our target. So first we'll look at the 2D view of the spine and we'll see where exactly we stand. And then we can slowly walk into the 3D picture, get all the 3D angulations and try to correct ourselves. So first looking at the 2D axis, that is the vertical axis. So when I am looking at this, I need to see where exactly do I stand. So am I at the spinous process or am I in the interspinous area, which is my target area from where I could walk into the space that I want. So if in case I am hitting the spinous process, how do I re-angulate or reinsert? We'll just look into that a little later. So the second axis, what we have is the horizontal axis. So in the horizontal axis, you could be on the either sides or you could be in the midline, that is the center, which is our area of interest. So if you are in the either side, then you need to understand which side are you, towards the right or the left, and what is the change in the angulation that you need to do so that you could reach the target. The third thing that you'll be looking at is the depth at which you're getting a bony hit. So getting a bony hit, what's the fuss about? Is it really such a bad thing to hit the bone? I don't really think so. So each bony hit that you get, you should be able to define which part of the vertebra are you actually hitting. And this information should be able to guide you to redirect the needle so that you could navigate the needle into the space. So let's decode those bony hits. So we have 4 scenarios here to just simplify the whole process and to look at it in a more 3D way. So initially, when I am entering with my needle, if I'm having a bony contact at the depth of only 2 centimeters, then it could be the spinous process. So here you have 2 options. Either, change the angulation cranial and try to walk over it. I wouldn't really suggest doing that because the angulation needs to be very precise and there's a chance that you'll go and hit the distal end of the upper spinous process. So what's usually recommended at this point of time is you remove the needle and then reinsert, again palpating the spinous process about 0.5 centimeters above or below the previous insertion point. This should be able to help you with reaching the target. So the second scenario is when my needle is getting a bony hit at a depth of about 4 centimeters. So now this is not the area of the spinous process. We have, gone beyond that. So what are we hitting at this point of time? So this could probably be the lamina. So if it is the lamina, what you need to do is you need to re-angulate or redirect the needle with a little medial angulation and cranial angulation so that you can reach the space, or simply you could just walk over the lamina and then slip the needle into the interlaminar space. So the third scenario, what we have here is that you're going in with the needle and you're getting a bony hit at a depth of about 8 centimeters. Here we have been a little confident and we have overshot the whole space and we have reached the other end. We are hitting the body of the vertebra. So at this point, what we need to do is we just need to carefully remove the needle or, keep withdrawing and look for the space and look for the CSF flow. This could also be because of some problems with the ligamentum flavum. We'll talk about that a little later. And the last scenario where you're not hitting anything at all. So at this point of time, you really need to question yourself, see where you stand and probably, reinsert or redirect your needles. So this has already been explained by Hamid, but we are just looking at the 3D anatomy of it so that, we could understand better what exactly are we piercing when we are trying to reach the subarachnoid space. So in the midline approach, you're going for the supraspinous ligament and then the interspinous, and what's painted yellow there is the ligamentum flavum. That's an area of interest. But in a paramedian or a paraspinous approach, we are bypassing this whole area and we are going with the alternate approach where we are just hitting the ligamentum flavum. We'll see that again. So this slide is basically on the causes of a failed spinal. There could be low CSF pressure, which is due to dehydration, or in elderly patients. Fetus et al. Have beautifully described the presence of a dural flap after piercing the dura, which could probably divert the drug away from the subarachnoid space. Also, if the orifice of the needle is not completely in, so part of the drug could be diverted away. So I'm not going to the basics of this and depth of this because this itself is a topic. So I will stick to the technical aspects that we are looking at. So our destination now, the target now is decided, that is the subarachnoid space, that is what we want to reach. So there are different approaches that we can take so that we could reach our destination. So could it be paraspinous, could it be midline, or could it be paramedian? So what's the difference between paraspinous and paramedian? Let's look into that. So let's look into the interlaminar area or the width that we have in the spinous process area. Okay, so this is what we have. This is the area where, we could probably enter. And this is the area we have, which is much wider. The interlaminar area is much wider when we take the paramedian approach. Then what is the reason we usually traditionally go for the midline? Because it's easier to palpate. You have like bony landmarks. For a beginner, it's easy to, just go above the bone and reach the space. And reaching the interlaminar space through the paramedian approach will need some amount of expertise and calculation of the angles. So it's not usually practiced. So why exactly are we going paramedian? Because as we know, supraspinous ligament and the interspinous ligaments are the ligaments which usually calcify. The ligamentum flavum does not calcify. So we are bypassing our problem. The problem we have is in the midline. So we are taking the alternative route to reach our target. So it could be because it's narrowed or fused or whatever the reason is. So paramedian approach is what is traditionally taught for us as trainees, where we are told that you need to keep the needle a good finger breadth away from the midline. Even if you look at all the articles that's defining the paramedian approach, it says you need to keep the needle about 1 to 2 centimeters away from the spinous process. I'm not a huge fan of this approach. I'll tell you why. So if our entry point is about 1 to 2 centimeters away from the midline, this is our path and we are trying to enter the interlaminar space. Okay, so if we angulate, here you need to calculate the angulation, could be about 20 to 30 degrees. And you have to calculate the angulation in a very three-dimensional way so that you could navigate the needle through the space, which is technically a little difficult. So in this video, if you see, I am marking the upper end of the spinous process and the midline. And in the right side image, you can see my entry point. That is, I've used a scale to show you exactly where I'm entering. That's about 1.5 centimeters away from the midline. So if you look at the video, I don't know if you can appreciate that. We are entering with the angulation of about 20 to 30 degrees, medial angulation towards, the midline. So at this point, if you observe carefully, I'm hitting a bony, I'm getting a bony hit there. I'm having resistance. I'm not able to navigate the needle. So I'm withdrawing it, increasing the medial angulation and a bit of cranial angulation to it. And then, sorry for that joke, it should be something I troubleshoot. But either way, we have got the CSF there. And that is the paramedian approach for you. So what exactly happens if we go to medial? In that case, you could be hitting the other spinous process. So if your angulation is too cranial and you're going too medial, you could probably hit the other spinous process. And if in case you're going too lateral, then you could be hitting the facet joints where the patient complains of radiating pain towards one side or lamina or the either way. So next, coming to my favorite approach, that is the paraspinous approach. This is my go-to approach whenever I have any problem with the midline. So why so? Here, the difference between the paraspinous approach and the paramedian approach is that your entry point is only 0.5 centimeters away from the midline. Okay. So when you are trying to enter this way, it negates a lot of difficulty that you have with the paramedian approach. That is, you enter with a constant angle of 10 degrees. And your idea is basically to hit the lamina. So you enter from a lateral to medial angle of 10 degrees and hit the lamina and you walk over it so that you can place the needle into the, you can basically just slip the needle into the interlaminar space. But here also, if the angle is too large, you could hit the spinous process. And if it is, too small, you could probably go hit the facet joints. So here we have a 8-year-old female who was posted for a hemiarthroplasty. So I have marked the upper end of the spinous process there and the midline in the second image. And in the third image with the scale, I'm trying to show you that I'm entering at only 0.5 centimeters. That is just slightly lateral to the midline. So it's also showed in the fourth image. And the fifth image shows the angle, that is 10-degree angle that I want to take. So if you look at this video, carefully observe the angulation I'm taking and where exactly it's my entry point. It's slightly just lateral to the midline and the angle is just about 10 degrees. At this point, I've hit the bone, which is my idea and which is my target. That is, I'm hitting the lamina. And here, I'm not bothered about any medial angulation. I'm just walking cranially over the lamina and to reach the interlaminar space, the subarachnoid space. So we have got the CSF there. So hitting the first bony landmark, that is the lamina, could be a vital step. And this could probably guide you to walking into the interlaminar space. So the next slide, what I have is comparing the paraspinals and the paramedian approaches. This is a beautiful article by KJ Chin and colleagues where they see the strategies for a challenging anatomy. So he has described it beautifully. That is when there is a distance of entry point for about 0.5 to 1 centimeters away from the midline, the amount of angulations that you need to choose from is very less. But when your entry point is about 2 centimeters away, you need to choose from your lateral to medial angle. You need to see at that angle what's the angle you'll get at the depth. You need to choose from the cranial angles. So it makes the whole three-dimensional angulation. That is, you need to triangulate your needle trajectory into the laminar space, which could be slightly challenging and difficult. So there is another article by Pythagoras and cousins where they measured the skin and the dural sac distance and the optimal angles in reaching in the paramedian technique. And they saw that adapting an angle of about 10 degrees lateral to medial with an insertion point of about 1 centimeters could be very helpful. So there are a lot of patient-centered benefits in also following the paramedian and paraspinous approaches. That is, the incidence of post-spinal headache and low backache is reduced. Probably low backache is reduced because you're entering through the paraspinal muscles. The muscular trauma could be probably less compared to the ligamental trauma through supraspinous and interspinous, but this is very debatable. I'm not going into that. The reduced incidence of post-spinal puncture headache could be probably because of the angulation that we need, the cranial angulation whenever we are using paraspinous or the paramedian technique. So this creates a dural flap, which has also been described in electrophysiological electromicroscopic images by Rena et al., where they show the dural taste post tenting by the needle, which leads to the formation of dural flaps, which could probably oppose each other and reduce, the post-spinal headache incidence. So there are a lot of studies which support the same inference. So when we try to compare the landmark-based midline and paramedian approaches for the complications, there are other studies which, have enrolled about 2,280 patients with 13 RCTs, and they're seeing that the first attempt success rate is higher in a paramedian approach when compared to the midline, and also the incidence of PDPH and LVP is lesser. So this is another technique that we have, that is the Taylor's approach. This is the original article by Sir John Taylor in 1940, where he stressed on the importance of the landmark of posterior superior iliac spine. So the entry point that he recommended was about 1 centimeter medial and below the posterior superior iliac spine. So the reasoning which was given at that point of time was that the L5 spinous process is pretty wide and it could probably obscure the view. So going, paramedian in this could help. This is again debatable. We are still able to achieve a good midline approach even with L5S1 interspace. But either way, we cannot deny or negate the idea that the L5S1 is definitely the largest interspace we have. So in case of difficult spinal, this should be our go-to space if the height of blockade is not a big concern. So whenever we are depositing the drug in a L5S1 space, we are giving the drug below the lumbar lordosis. So there is a chance that we may not, achieve the height that we need if we don't do the manipulations that's required. So this is a patient who was 75-year-old and has history of multiple surgeries with difficult spinal where a lot of pricks were given prior. So for this patient, we went ahead and thought of using a Taylor's approach. So I have marked the surface landmarks and also my entry point that I want to take. Here I'm entering, if you can appreciate, with an angulation of about 55 degrees. With a medial and cranial angulation, I'm trying to reach the interlaminar space. So when I'm going inside, I got a loss of resistance, no CSF, probably the epidural space, and we are walking further inside. And there we have the CSF. So we are going with an angulation for about 55 degrees to reach the interlaminar space. So these are all the techniques that we saw when we are able to position the patient with a flexion, that is in sitting or lateral decubitus, whatever the position is, we are able to achieve a flexion of the spine. But what about situation where we are not able to flex the spine? The patient needs to be, in extended position for whatever reason that is. So do we have any approach when it comes to this? So I came across some of the very interesting articles by Sir Janel McLean. McLean's point is this a novel technique. So I have myself tried 3-4 times, not more than that, for some patients whom I couldn't position in flexion. And surprisingly, all 3 times I have been able to achieve the central neuraxial blockade in one shot. So here, if you see the point of entry in the right side image that I'm trying to show, it's about 0.5 centimeters lateral to the lower end of the spinous process. So in all the approaches we spoke till now, we are trying to look at the upper end of the spinous process. Here we are looking at the lower end of the spinous process and about 0.5 centimeters away. Here what Sir has explained is that you don't need to have any angulation. That is, you go bang on perpendicular and you reach the space. So these are the images which I took from Sir's demonstration itself. So this is the transverse cut or the view of the vertebral column and the spinal cord. The lamina and spinous process are marked, and you can see the area of interest. So a direct entry, walk in to where we need to go. So in the right side image, you can also see the space, the interlaminar space that is available and our point of entry. So this was the publication where they have told 0.5 centimeters paraspinous to the lower border of the spinous process and directly perpendicular so that you could reach the subarachnoid space. This is something definitely that could be tried. Coming to the next aspect of presentation, I'm not going to much details of this, but by being a regional anesthetist myself, my inclination or the interest is always towards holding the ultrasound probe. So whenever there's a problem, my usual thinking to troubleshoot is always holding the probe, but I'm not going to talk about that. Viral will be dealing with this. So you could probably have a real-time ultrasound guided spinal anesthesia or a pre-procedural ultrasound assisted spinal anesthesia whenever there is any problem. So just trying to compare ultrasound guided versus landmark, we cannot deny or negate the advantages of using the ultrasound. So 22 trials in this paper with 2462 patients, they saw the increased first pass success rate with the pre-procedural ultrasound. Also, they saw that there was no much time difference by using a pre-procedural ultrasound to just landmark guided technique in obstetric patients. Here's another paper by UG and colleagues where they saw that the first pass success rate and patient satisfaction was better when used with the real time and real time or even the pre-procedural ultrasound compared to just the anatomical landmarks. Even the first pass success rate was much better with the pre-procedural ultrasound. So next, coming to the anatomical considerations of a thoracic spine. So I'm just going into basics of this. I'm not very much going into the epidural as such. The technical aspects of epidural could be extrapolated just from this information of giving a subarachnoid block also. We are not going into segmental spinal or what kind of drug, how much volume we need to give. That's not where we are headed. But we are going to troubleshoot how we try to reach the subarachnoid space in the thoracic level also. So the thorax could be divided into the upper thorax, the mid thorax, and the lower thorax. So T1 to T4, the upper thorax, the angulation, as we saw earlier in the 3D model, is not much. So the interlaminar area is along the upper edge of the spinous process. So your needle insertion point could be about 1.5 centimeters lateral and below the upper edge of the spinous process. But our area of interest, mainly where we encounter all the difficulties, is the mid-thoracic area, that is between the T5 to T8 area, where we have the maximum angulation at about, 40 to 60 degrees. So in the mid-lamina area, if you look at these images, you can see that the base of the spinous process is very wide. It's almost obscuring your entire view. There's no window to enter there. So forget about, just a blind or a technical aspect of it. Even ultrasound needs some amount of manipulations and some amount of expertise for you to be able to visualize and get that window to enter the space. The mid lamina area at this area is at the same level of the upper edge of the spinous process. So your needle insertion point could just be about 1 to 1.5 centimeter when we are talking about the paramedian approach, lateral to the upper edge of the spinous process. So we need to remember that the base of the spinous process is pretty wide in this area. So if you look at this image, this is the angulation that the needle needs to reach the thoracic space. So it's very much angulated at about, 40 to 50 degrees. If you look at the right side image, the first image, just look at the tip of the spinous process. They are not always in the same line. That's what I was trying to tell. And why is this important? Because when you're trying to enter with the needle in the next image, you could probably hit the base of, the spinous process from where you're trying to enter itself. Or you could also hit the spinous process above, because, the angulation you need to manipulate based on this. So it's important for you to understand what exactly is the anatomy at this point of place, so that you could manipulate and redirect your needle. So paramedian approach to the rescue, paraspinous or paramedian, I'm just using the term paramedian here. So enter at about, 0.5 to 1.5 centimeters, depending on what approach you're trying to use, and try to target the area. But you need cephalid angulation of what is seen in the first image for you to reach the space. So the lower thorax about T9 to T12, it's almost like the lumbar area. So we shouldn't be having much problem in establishing the space here. So next, coming to the ligamentum flavum. So we know that the ligamentum flavum is robust in the midline. There are some described gaps which we could frequently observe in the midline. So you may not always get that characteristic loss of resistance when you're trying to reach the space. And we know that the posterior epidural space is the largest in the midline. So this article by Lurk et al. Shows the incidence of lumbar ligamentum flavum midline gaps. So they told that the maximum gaps were frequently observed between L1 and L2, and also there were some amount of gaps in the lower thoracic areas, specifically T10 to T12. So we need to consider this whenever we are trying to do central neuraxial block, that you may not always appreciate that characteristic loss of resistance, and at times when you're trying to place the epidural, you might get a CSF tap. So these are all the studies that are supporting the paramedian approach when it comes to the thoracic area. And even when we are trying to place the epidural, there are enough epiduroscopic studies. Definitely not the lesser paresthesia and the autopsy. That's just one of the benefits that we have. Usually, whenever we are trying to place the epidural by a paramedian route, it's easier to place. You have lesser paresthesia. And in this study, with the epiduroscopy, they saw that there's more likely chance to advance the catheter more cranially, probably owing to the angulation that we use whenever we are using a paramedian approach. So the approach to the central neuraxis in challenging anatomy could be because of obesity, scoliosis, pregnancy, or elderly. This was one of the pregnant patients whom we had with scoliosis. So the first step when it comes to troubleshooting a patient with scoliosis is to always determine where is the convex curvature. So whenever we are dealing with the patient with scoliosis, you need to know what is the curvature, what are the rotations. So ultrasound beyond doubt could be of great help. And for people for whomever like ultrasound is not accessible, you could probably use the pre-op radiological images that you have to look at the curvature and the rotations, and also by palpation and inspection. So the basic idea is for you to establish where is the convexity of the spine. So interlaminar spaces are easier to enter and it is wider wherever the convexity is. So that is our target. So if you look at the last image, some amount of rotation of spine exists in scoliosis. So this rotation kind of negates the needle, even if you're entering with, a paramedian or a paraspinous approach. The amount of medial angulation you need to have to reach the interlaminar space is negated by the rotation of the spine itself. So maybe like in a patient with scoliosis, you don't really need to angulate with a huge angle when we are trying to target the space. Next comes the patient with obesity. So there are a lot of challenges even in an obese patient, and we know the fact that Taffier's line does not always coincide with L4, L5. There are a lot of studies showing this. It's not necessarily in the same space, so you could be placing a needle much higher in these patients. So you should have that in mind. Ultrasound, then again, a huge role to play when it comes to all of this, but even ultrasound has some amount of limitations when it comes to scanning a obese patient, because it's not very easy and needs some amount of expertise to try to locate the target in that depth. We'll definitely need the longer needles. So in this patient, even though the patient is very obese, half of most of the time the fat is deposited away from the midline, so probably we could make use of that. So what I usually do when I am trying to give a spine in obese patient is I try to look for the midline, but if we are not able to do that, I just enter with the needle and try to let that help me out with where I'm trying to head. So get your first bony hit, try to understand the anatomy of where you're hitting, if is it the lamina or spine or how exactly it is, and then you could re-angulate or redirect your needle to try to enter the interlaminar space. Definitely paramedian paraspinous approaches, especially paraspinous approach, is very helpful in patients with obesity. So some of the tips and tricks to conclude: cannot stress enough on the importance of having a 3D mental model. The spinal process as such could be blind, but then it's extremely important for you to know where exactly you're hitting. When you are getting a bony hit, you need to understand what you're hitting and how do you need to redirect. It's not random redirections that you make. You need to understand what you're trying to, where you're trying to go, where do you stand now, and what is your target area. Good needle handling technique with small incremental and controlled redirections. Paraspinous approach, hands down superior to paramedian, and practice makes everything perfect. So these are my references. First and foremost, I would like to thank Meenakshi Sundaram sir for giving me this wonderful opportunity on such a big platform to present. Since my topic is troubleshooting the neuraxis, I have put a collage of my neuraxis. That is my family, which always supports me with everything. And also, I would like to thank my guru, Dr. Balvenkat Subramaniam sir, and all my mentors and teachers from Ganga Hospital, Coimbatore, who have taught me the little regional I know. And also, a huge thanks to all my colleagues and teachers from Yenapaya Medical College, Mangalore. They are all seen in the image on the right side. They always support me with everything I do. So thank you so much. And thank you for having me. Handing it over to Viral for further troubleshooting the neuraxis with the ultrasound.
Thank you, madam, for an elaborate presentation. Now we will move on to the third topic, that is ultrasound guided spinal anesthesia. Over to the speaker.
Yes. A very good evening to all of you. So at the outset, I would like to thank Dr. Meenakshi Sundaram sir for giving me this opportunity and the ISA Pudukkottai branch. My topic for today is ultrasound guided central neuraxial blocks. Most of my job has been done by Dr. Hamed and Dr. Shilpa by describing the various aspects of the anatomy. So I'll be dealing basically only with the ultrasound aspects of how to give central neuraxial blocks. So before proceeding with the ultrasound, a little bit about the history. So in 1885, long back, Professor James Leonard Corning described the epidural anesthesia at first. In 1898, August Bayer performed the first intrathecal anesthesia, and he's considered as a father of intrathecal anesthesia as he performed the intrathecal anesthesia on himself. So central neuraxial blocks traditionally spinal and epidural, we are performing by identification of interspinous spaces by palpation and tactile localization of bony landmarks for needle insertion. And Tuffier's line or intercrystal line, it has already been described. It is a virtual line which connects the highest points of the iliac crest, and it generally intersects the spine at L4 spinous process or L4 L5 intervertebral space. So this all of us are traditionally been doing, and this is the first thing which we are taught when we enter the anesthesia branch, the spinal, which is the basic or bread and butter for us. But a question arises in our mind that how accurate it is. Are we always entering the perfect space? Does Tuffier's line always correspond to the L4 L5 interspace? There have been multiple studies which have described and demonstrated that it is not correct. So this is a study from 2019 about the accuracy of Tuffier's line identification by palpation method in obese, pregnant, and control groups. So what they mentioned was that the palpation method was found to be inaccurate surrogate for L4, L5 vertebral interspace for obesity with or without pregnancy. Coming to the next article about the vertebral level of Tuffier's line, which has been measured by ultrasonography in parturients in the lateral decubitus position. So what they concluded that the vertebral levels were more capillary in the parturient woman compared to the non-parturient woman had we not scanned with the ultrasound. So if we had palpated the Tuffier's line, and if we would have thought that it is corresponding to L4, L5 interspace, but it could have been L2, L3, and so on. And these are the results of their study. What they found that in the pregnant patients, most of the patients had the Tuffier's line corresponded to L3 and L4 segment compared to the non-pregnant patients where it was around L4, L5. So had they not scanned, if we don't scan the spine, we are bound to enter a higher space, which we don't desire. Similarly, in the elderly women, there's another study by in Korean journal. They commented that the vertebral level of Tuffier's line determined with ultrasound measurement in the left lateral decubitus flexed position was more capillary in elderly women than those in control group. Similar to the previous study, as we can see here, they studied 50 patients in each group, and they saw that in elderly patients, almost 40 to 50% of the patients had the Tuffier's line corresponded to L2, L3 or L3 interspace compared to the control group. So again, we are bound to enter the higher interspace, which we don't desire if we don't scan the patient with the ultrasound. So what is the clinical significance? Irrespective of whether we are using the Tuffier's line as an anatomical landmark, are we safe? So as already described by Dr. Hamed, that the spinal cord ends at the level of L1 vertebrae and the level of L1 vertebrae. However, in this case report about the damage to conus medullaris following spinal anesthesia, what they found that in 7 cases they dissected the patient. It's a cadaveric study, so they found that after scanning the patients with MRI and the dissection, around 50% of the patients had the lower level of the spinal cord ending around L2 lower or L2 mid and L2 upper segment. So there is a possibility of damage to the spinal cord, and there is a risk of spinal cord injury. So most of this patient, the risk of injury we find is mainly in morbidly obese patients, the pregnant patients, elderly patients, patients with spinal anatomical deformities, and post-spine surgery patients. So what are the advantages of the ultrasound? It is non-invasive procedure. There is no radiation exposure. It's a bedside procedure. It can be reproduced and repeated multiple times as we have the ultrasound machine in our theater itself, and it does increases the success rate. Also, it helps us to identify the midline. It helps to identify the intervertebral level. So whether we are performing the epidural, suppose for a abdominal surgery, if we are performing at a higher level like T10, T11 or T12 level, we can accurately identify the intervertebral level for performing spinal or epidural. It helps us to guide the needle insertion angle and trajectory. It also helps us to identify the depth for epidural and intrathecal space. So we can get a rough idea that how deep we'll be getting the CSF fluid if we are aiming for the spinal. And it also acts as a guide for certain anatomical variations like deficit in ligamentum flavum, spinal deformities like kyphosis, scoliosis, and post-spine surgery. So this article has already been quoted by Dr. Shilpa about the incidence of ligamentum flavum midline gaps. So as we can see that there are variations in the ligamentum flavum morphology. The picture on the right shows that the ligamentum flavum is completely fused, whereas on the left side it shows that there is a definite gap in the ligamentum flavum. So what is the incidence of midline gap in the ligamentum flavum? So as we can see from this study, it is mainly at the level of L1, L2 compared to the lower levels. And they also commented that the ligamentum flavum gaps are most frequent at L1, L2 and are more rare below. So using the midline approach, one cannot therefore rely on the ligamentum flavum to impede entering the epidural space in all patients. And we have already observed quite a bit time that we are entering for the epidural space and we don't get a classical give way for puncturing the ligamentum flavum, and suddenly we get a CSF tap. Suppose if we scan this patient later on, we will definitely see the ligamentum flavum gap in the ultrasound image. I'll show you a picture later on about that image of the ligamentum flavum gap. So with the help of ultrasound, studies have identified that it decreases the number of attempts, it reduces the number of passes, it reduces the vascular injury and the incidences of bloody tap, definitely reduces the pain score and complications. About the procedural time, yes, at start, the learning curvature for ultrasound is there, but as you progress with it, the procedural time is almost similar to a blind technique, specifically in a difficult patient. Also about the number of attempts and number of passes. So what is the difference? So number of attempts is after you prick the patient with the spinal or epidural needle, if you remove the needle and if you re-prick it, so it is considered as a number of attempts. And the number of passes if you just redirect the needle with that same prick. However, in spite of so much advantages of ultrasound, why is it not utilized regularly? Because as I already previously mentioned that most of our seniors and we have been taught initially the traditional landmark guided technique, and there have been studies which have compared like this about the complications of central neuraxial block. This was a third national audit project of the Royal College of Anesthetists, and they mentioned that the incidence of permanent injury due to central neuraxial blockade was very less, about 4.2 percentage, and the risk of death or paraplegia was around 1.8 per 100,000 patients. So most of our colleagues might say that we have been performing this like for decades, but we have never faced this complication. So there is definitely some kind of hesitation for using the ultrasound. Obviously, it requires a higher learning curve. It has a higher learning curve and definitely needs a lot of practice before you can master it. Yet again, it is relatively difficult to identify the soft tissue window around bony framework of spine. So normally when we are doing other blocks like a supraclavicular block or an interscalene block, the ultrasound gives us a very classical picture. But since the bone is not a friend for ultrasound, we cannot see the classical picture and we have to uh, adjust our picture in such a way that we get a classical window for entering our spinal or epidural needle. Also about the difficulty in availability of ultrasound. Definitely in India, the PCP and it is a major issue for smaller nursing homes and smaller places. So the possibility of acquisition of ultrasound is also a problem. Coming to the history of ultrasound for spine. So it was first described in 1971 in Russian literature. In 1980, Koch et al. Used ultrasound to delineate neuraxial anatomy. Between 2001 and 2004, Thomas Grau and colleagues conducted series of investigations that demonstrated utility of ultrasound in epidural analgesia. And from 2010 onwards, Dr. Manoj Karmakar and colleagues, and they all have done a very good job. So the anatomy of the spine, it has already been described. So this is the posterior view, lateral view, and the anterior view. Basically, I'm covering mainly for the spinal anesthesia and epidural at the level of lumbar spine. So the parts of the vertebra has already been described. It is the vertebral body, the vertebral arch. Posteriorly is the spinous process, the laminae. Laterally are the transverse processes and the pedicles, and the superior and the inferior articular processes. This superior and inferior articular process unite and they form the facet joint. So the technique of ultrasound, again, it is like the ultrasound assisted and ultrasound guided. So ultrasound assisted is like pre-procedural scanning and marking, and ultrasound guided is the real-time scanning. Today in this talk, I'll be mainly focusing on the ultrasound assisted or pre-procedural scanning and marking technique. So what are the requirements? We definitely need strict aseptic precautions like how we do a normal spinal, which there should be no compromise on that aspect. We need a low frequency curvilinear probe since the structures are deeper. So as we all know that a low frequency probe provides us with better penetration. We need a sterile marker pen so as to mark the specific intervertebral spaces, a sterile probe cover to cover the ultrasound probe, a coupling medium. If we are using a jelly, it should be a sterile jelly, or normally we are using a normal saline or betadine. Now coming to the ergonomics. So as all of us know that before performing any ultrasound procedure, ergonomics is of utmost importance. It can be performed in the sitting position or in the lateral decubitus position. However, the person performing the procedure, the patient and the ultrasound screen should be always in a straight line. Coming to the sonoanatomy, as I already mentioned that bone is not a friend for ultrasound. So we need to identify characteristic patterns before we take the patient for a spinal or epidural anesthesia. Also for scanning with ultrasound, we need to know various planes like the transverse plane, the median plane, the sagittal plane, and so on. I'll explain further. So this is a very recent article about the ultrasound imaging technique for spine for central neuraxial blockade. And they have described the two transverse views and the three parasagittal views on which I'll be focusing mainly. So what are those? So the ultrasound views in the transverse, we have transverse spinous process view, where the ultrasound probe is on the spinous process. Then transverse interspinous view. Then in the parasagittal, we have the parasagittal oblique interlaminar view, parasagittal articular process view, and parasagittal transverse process view. So let us start first with the transverse spinous process view. Now in this picture, you can see the patient is in sitting position. I'm performing the scan pre-procedure using the curvilinear probe, and the ultrasound beam is hitting the spinous process. Now, as I said that no ultrasound waves progresses or passes through the bony structure, and we can see in the ultrasound image, this is the transverse spinous process view. So we can see in the center is the spinous process and it casts a black shadow beneath. This is the lamina. And on the lateral aspect, these are the two erector spinae muscles. Now, as I take my ultrasound probe either cranially or caudally, and then my ultrasound beam will be between the two spinous process and it is called as a transverse interspinous view. So now, as we are scanning up or down, the ultrasound beam is passing between the spinous process and we get this classical view. So what we can see here is the uh, erector spinae muscle on both sides. This is the posterior complex. This is the anterior complex. These are the articular processes, and lateral is the transverse process. This classical picture, it resembles like a bat wing. So it is also called as a bat wing appearance. And as I mentioned about the posterior complex and the anterior complex. So what is posterior complex? So when you're scanning with the ultrasound, the ligamentum flavum, the posterior epidural space, and posterior dura are usually seen as a single structure. In few patients who are thin and lean build, we can definitely demarcate the ligamentum flavum and the posterior dura differently. Otherwise, they are being described as a single unit. And the anterior complex is formed by the anterior dura, posterior longitudinal ligament, and posterior aspect of the vertebral body. Out of this, in the posterior complex, the posterior dura is the most hyperechoic structure. So this is the video of scanning in the transverse scan. As you can see, my probe is moving up and down on the left side of the screen, and on the right side, the ultrasound image. This is the transverse spinous process view. We are not seeing anything. And in the interspinous view, we are seeing the articular process. This is the spinal canal. This is the anterior complex, and this is the posterior complex. So this is a classical transverse spinous process view. So this is how we can do the transverse scan. Now coming to the parasagittal scan. So this is the pictorial image, how the ultrasound beam will interact with the vertebrae. Coming to the parasagittal oblique interlaminar view. Now again, the patient is in the sitting position. This is the vertebrae, and now my probe is just lateral to the midline, and I have tilted it slight degree of angulation. So as we know that, as already described by Dr. Shilpa, that we are in the paramedian or paraspinous view, we are entering through the interlaminar spaces. And this laminae, we can see here, there is a classical gap between the two laminae. So this appearance has been described as a horse head appearance. So as we can see in this picture, this is the anterior complex. So in the ultrasound image, in the parasagittal oblique interlaminar view, if we are able to identify the anterior complex, it means that there is a potential space through which our spinal or epidural needle can pass through, and it acts as a surrogate marker for introduction of a spinal or epidural needle. Now this is a video of the parasagittal oblique interlaminar view. So in this scan, my probe is just lateral to the midline, and as you can see, as I'm moving from lateral to medial, this is at the level of articular process, and now my transducer is medial. These are the laminae, and this is the anterior complex, and this is the posterior complex. So this is the video of the parasagittal oblique interlaminar view. Now coming to the parasagittal articular process view. So what has happened is now my transducer probe is little bit more lateral as compared to the previous scan, and as already been described, that the superior and inferior articular process unite with each other and they form a facet joint. Since they act as a since there is no gap in between the articular process, they appear as a continuous wavy structure on the ultrasound image. And this classical appearance has been described as a camel hump appearance. Now, as I move my transducer more laterally, it is going to hit the transverse process, and it is described as a parasagittal transverse process view. So as we can see in this image, this is 1, 2, and 3. These are the transverse process, and this is the superiorly is the erectospinous spinae muscle. And this classical sign, it has been described as a trident sign. So what is this is a video about scanning for the parasagittal transverse process and the parasagittal articular process view. As we can see here, at this level, when I'm more lateral, my ultrasound beam is hitting the transverse process, and this is the classical trident sign. As I'm moving more medially in the image, it is the articular process. At the level of articular process, we are seeing the camel hump appearance. Now, after knowing this 5 views, we need to know how we should systematically approach the scanning procedure for the spine, how we should mark the level, how we should identify the depth at which we can get the spinal and epidural space. So again, the patient can be in the sitting or lateral position. We need to use a curvilinear probe. Ideally, the orientation marker should be kept cranially, but you can keep it either way. So the first thing is what we do is with a patient in sitting position in this picture, the orientation marker cranially, my probe is at the level of sacrum. So the sacrum, we can see in the ultrasound image, it appears as a hyperechoic structure, and the first gap between the sacrum and the L5 laminae, this is also called as the L5S1 gap. And as we can see in the image that the sacrum is more superficial to the skin as compared to the L5 vertebrae. And also I need to stress upon that the L5S1 gap or the L5S1 space is the widest of all the spaces amongst all the intervertebral spaces. So this is the first point from where you should start scanning. Now you need to move your transducer cranially. So as you start moving your transducer cranially, So, and we are in the parasagittal plane. At the level of laminae, we will see this classical horse head appearance as I already described. And this is the L5 laminae, this is the L4, and this is L3. This is the cranial end, this is the caudal end. Now, regarding the appearance of the parasagittal, how to do the parasagittal oblique view, how to do the marking. So as I mentioned about the sacrum and the L5S1 gap, now in this image, what we do is, see, this is the gap between the L4 and L5 vertebrae. What I have done is the space between the two vertebrae, I have kept it in the center of the screen. And I have told my assistant to make a horizontal line through the center of the probe, because this point on the screen corresponds to the center of the probe in the right image. Now I start to move my probe more cranially. Again, I'll keep the ultrasound image between the L3 and L4 laminae in the center of the screen, and I'll tell my assistant to make another horizontal mark. Like that, I can go on marking at whichever level we desire. After performing the horizontal line, I turn my ultrasound probe in the transverse orientation. Now in this image, what I do is I try to get a picture of the transverse interspinous process view, which I already mentioned, because there is a potential gap between two spinous process. And keeping this picture in the center of the screen, I tell my assistant to make a vertical line at this level. So similarly, we can identify a particular space at which we want to perform a spinal or epidural, and we can mark it. I want to stress upon this. See, the markings have been done pre-procedure. After this, we'll be cleaning the patient's bag either with a betadine or a chlorhexidine. These marks can go off. So what I usually do is, with the back of the tip of the needle, I make this prominent markings on the patient back. So after cleaning, those impressions do stay back. And during the scanning in the transverse scan, obviously, we need to identify the depth of the posterior complex. As we can see in this ultrasound image, in this patient, we are definitely going to get a spinal at 5 centimeter. Now coming to the angulation of the probe, as Dr. Shilpa already described about the various angulation, how we can change the angulation of the probe. So in this scan, my ultrasound probe is banks parallel to the ground. However, if we are getting this transverse spinous process with angulation of the probe, so that degree of angulation of the ultrasound probe helps us to guide the direction of the needle, whether it's a spinal or epidural. Now in this patient, this is the video about how I have, how we are marking the patient, the horizontal line and the vertical line. This is the right side is the cranial end and left side is the caudal end. And the point of intersection of those 2 points, to that point you should introduce a spinal or epidural needle. There have been multiple studies which have been quoted by Dr. Shilpa. This is one of our own study about anatomical landmark guided midline versus pre-procedure ultrasound guided midline technique in elderly patients. And what we found that the in the ultrasound image, the first attempt success rate was almost 90%. This is another article about conventional landmark palpation versus pre-procedural ultrasound for neuraxial analgesia and anesthesia in obstetric patients. So what they commented that the pre-procedural ultrasound increased the first pass success rate. Also, it increased the benefit of pre-procedural ultrasound in whom the neuraxial procedure was predicted to be difficult. Complications including postpartum back pain and headache were decreased with pre-procedural ultrasound, and the adoption of ultrasound in obstetric is recommended, and as it increases the efficacy of a successful spinal or epidural. There have been multiple articles which have been come up regarding the ultrasound imaging, which facilitates spinal anesthesia in adults with difficult surface anatomical landmarks. Also, there have been multiple systemic reviews and meta-analysis have come. Also, these are the few articles describing about the pre-procedural scan in elderly patients. Now coming to the thoracic spine, I won't be going into much detail about the ultrasound spinal and epidural in the thoracic spine. As Dr. Shilpa has already commented and Dr. Hamed has also described about the angulation of the mid-thoracic spine, basically from T5 to T8, even the ultrasound scanning is difficult because there is no appropriate window for ultrasound beam also to pass practically in the transverse orientation. This is a very excellent article about real-time ultrasound-guided mid-thoracic epidural access using a novel paramedian cross view and drip transfusion technique by Dr. Shiva Shanmugam. And they have described basically 5 views for scanning the thoracic spine. The first view is the paramedian sagittal costal view. So what they recommend is you can do this either on the dependent part or on the non-dependent part. So what they have done is from the dependent side, the patient is lying in the lateral position. The ultrasound probe is at the level of ribs. And this is, as we can see in this image, these are the ribs and this is a pleura in between. In the second view, the paramedian sagittal costotransverse view. So the ultrasound probe has been moved more medially. And this is at the level of costotransverse junction. This has been described as a step sign. So this is the transverse process and this is the rib. Now coming to the paramedian sagittal transverse process view. So as the ultrasound probe has been moved more medially, this has been described like a classical trident appearance or the trident sign what we see at the level of lumbar vertebrae. Now coming to the fourth view is the paramedian sagittal laminar view. So I want to stress upon this image basically because I already mentioned about the paramedian sagittal oblique view at the level of lumbar spine. There we were very much able to see the posterior complex and the anterior complex. But because of the angulation of the spinous process and the overlapping of the laminae at the level of thoracic spine, the gap between the T4, T5, and T6 laminae is very less. So, so in spite of using ultrasound, it is difficult to get the interlaminar space. But in this picture, you can see the posterior complex and the anterior complex is not very much seen in this picture. And the last is the paramedian cross view, which they have described this. So what they have done is after coming at the paramedian sagittal laminar view, they have tilted the probe in such a way that the cranial end is at the level of the base of the T4 spinous process. In the middle is the T5 laminae, and at the lower level is the T6 transverse process. And what they have described is, if we insert the needle in this paramedian cross view, the needle is definitely going to enter between the two laminae. And they have demonstrated this very nicely in this image. So we can see that the needle is entering, and this is the base of the T4 spinous process, and this is the laminate. Now a little bit about scoliosis. As we all know that we are not regularly having patients with scoliotic spine, but suppose if we get a patient with scoliosis and we are not able to give general anesthesia, or the patient is high risk for general anesthesia, how to go about it? This is another image from an article. As we can see, the patient has got a thoracolumbar scoliosis, and we all know that even with the traditional technique, we perform the spinal or epidural from the convex aspect. As we can see in this picture on the X-ray, there is crowding of the ribs on the concave side, and the interlaminar spaces are more wider on the convex aspect. This is another article about clinical implications of neurexual anesthesia in a parturient with scoliosis. So what they have described is, this is the plane of the back, and if we go in a, if we just palpate the spinous process and we go bang perpendicular to it, we are definitely not going to enter the spinal canal. So what we need to do is we need to angulate the needle. So how does ultrasound scan helps for patients with scoliosis? Again, there are two approaches which have been described, is the paramedian approach and the midline approach. And as I already mentioned, so what happens is if we put the ultrasound probe at this level, what we can see is the spinous process, and these are the two transverse process. So now at this level, in the left image, we can see that the transverse process on the right side is more closer to the skin compared to the left side. That's what we are seeing in the ultrasound image. Now, with a little bit of angulation, uh, we aim to target that the laminae or the transverse process on each side are at the same level. That's and after doing this, we need to mark, and in that angle, we need to introduce the needle. So this is how we need to mark this spine. What we can do is we can start scanning from above down, and depending upon the level at which we want to perform spinal or epidural, we can mark. This is in the transverse scan. Now in the parasagittal scan, again similar to the normal spine. After knowing the midline and the spinous process, we need to feed the ultrasound probe just lateral to the midline, and we aim to target for the parasagittal oblique view at the laminae, and we tend to identify the anterior and the posterior complex. A little bit about caudal epidural, since we are dealing with the central neuraxial block. I'll be focusing mainly on the ultrasound imaging and how we go about it. So again, this is the patient's back. We keep the ultrasound probe at the level of sacral cornua. As you can see from this image, these structures which are the left and right sacral cornua, as we can see on the ultrasound image. And this hyperechoic structure, which you can see, is the sacrococcygeal ligament. This is the reverse ultrasound anatomy showing the same. So what we can do is after obtaining this image in the transverse scan, we can go in the either out of plane approach. We can puncture the sacrococcygeal ligament and we can perform our spinal or epidural. This is the similar caudal epidural in the vertical scan or the mid longitudinal scan. So what we can see in this image is, again, this is the sacrococcygeal ligament which we need to puncture. The needle is entering from the caudal end. Few of the case scenarios which I have experienced, I would like to share with you. So this was a 66-year-old, 108-kilogram patient with a BMI of 43 for TKR. So again, in this patient, we did a pre-procedural scanning and marking of the patient. What I would like to emphasize is this were the on the right side, this were the marking which was done pre-procedure. And after thorough preparation of the spine and with aseptic precautions, when I palpated the Tuffier's line and I presumed that that is my L3, L4 interspace, but no, this is a red line which was which I presume that it is the L4, L3, L4 interspace. But as I already pre-scanned, the L3, L4 space was quite lower, and this was the L4, L5 interspace. And after, in the same patient, we just measured the depth to the posterior complex, and as we can see, it was around 5.02 centimeter. Again, I would like to stress upon this aspect in obese patients mainly, since they have a lot of fat posterior on the posterior aspect. So in this image, while scanning and marking the depth for posterior complex, I had used the curvilinear probe. I had applied a lot of pressure on the patient's spine. So in this patient, our spinal or epidural will come a little bit more compared to 5 centimeter. That depends on the thickness of the fat. So it might come around 5.5 to 5.5 to 6 centimeter. So depending on the patient's body habitus, that margin of error we need to keep in mind. So in this patient, after marking, we performed the spinal and we got the CSF in a single prick. This is another patient. He was a 28-year-old, 149 kilo patient with a BMI of 45.9 for ischiorectal abscess. So in this patient, he was in so much pain that he was not able to sit in a sit. He was not able to lie down in a sitting position. So we did the scan in the parasagittal in a lateral position. So what I would like to emphasize is the picture which we usually see in a volunteer or a thin-built patient is not what we see in difficult patients. So as we can see, this is the transverse interspinous scan. Here we are not very much able to identify the anterior complex, but definitely we are able to see a little bit of the posterior complex. This is the video of the same. So this is again the parasagittal oblique view. Here we can see the laminae, and as we move more medially, this is the anterior complex. And this is the posterior complex at this level. So that's what I would like to emphasize, that in the difficult patients, the imaging might not be as clearer as it's seen in the books and what we do or what we see in a healthy volunteer. And in the same patient, this is a transverse scan. So this was a transverse interspinous view. As it's a bony structure, we are not seeing any thing more anteriorly. And as I move more cranially or caudally, this is the transverse interspinous view. So it was definitely a difficult scan. This was a 38-year-old female with a severe PIH, morbidly obese with a BMI of 49 for a elective C-section. So what we did is we did the scan in the patient's room preoperatively. And as you can see in this video, again, the imaging is not as good, but we are very much happy that we are able to identify the anterior complex in the parasagittal oblique scan. We can see the classical horse head appearance of the laminae. And so we were very much comfortable that suppose this patient comes for emergency, again, we can do the scan and we will be definitely successful in getting a CSF. This is a classical view, which we can see the anterior complex in this picture. This is a transverse scan for the same patient. Again, the imaging is not as good as I showed previously, but we are definitely able to identify the anterior complex. This is the spinous process view, and this is the interspinous view. Here, as you can see, the posterior and the anterior complex, and this is the spinal canal. So in this patient, we obviously measured the depth to the posterior complex. It was around 7.47 centimeter. Now, about the ligamentum flavum deficit posterior complex, or the ligamentum flavum gaps, what we discussed previously. So this was another patient in which we can see here that the posterior complex is not complete. So in this patients, we were obviously we didn't perform an epidural. We are doing a spinal anesthesia, but we were aware of it that in this patient, the epidural, if we perform an epidural, we might not get a classical give way. This is the another patient with a severe kyphotic spine and a scoliotic spine. She was around 88, 89-year-old female who had come with a restrictive lung disease for a bipolar surgery as she had fractured the femur neck. So what we did again in this patient, the transverse scan was not great. This is the parasagittal scan. This was the sacrum which I was able to identify, and little bit of the anterior complex which we are able to appreciate. So that's what we marked in that patient, and we were very much lucky that we got the CSF tap and we were able to avoid general anesthesia in those patients. That patient. So the take-home message is definitely ultrasound scanning for the spine. We are looking for the deeper structures. We need to use a curvilinear transducer. We need to repeat scanning in the normal patients. The sonoanatomy, we need to know the characteristic patient patterns. The patient position should remain, again, I need to stress upon this point. So if we are doing a pre-procedure scanning, the patient position should remain the same in the position which we have marked. The actual depth could be more than the measured depth, as I mentioned in the obese patients. The angulation of the probe helps us to identify the angle in which we need to insert the needle, and we need to keep an eye for possibility of gaps in ligamentum flavum. Thank you so much.
Thank you, Dr. Viral, for excellent presentation. All the three speakers have done their job very good. Now it's a time for taking up the questions. There are a few questions in the chat box. First one is from Dr. Vikram Rathod. He has asked 5 questions in fact. How to take help of ultrasound in obese patients? That already Viral has explained, so no need to go into deep again. The technique of using 27 and 29 gauge spinal needles. Dr. Viral, you
Yes,
want to
sir. Sure, sir. Thank you, sir, for this question. The technique of using 27 and 29 gauge spinal needles. So, see, basically, in such needles, we are using a Whittaker needle or a Sprott needle, which has an introducer. So, the introducer is slightly sturdier compared to the spinal needle. So, what I would recommend is if you are doing the traditional technique or if you are using an ultrasound technique, just identify the angulation in which you need to introduce the spinal needle, then introduce a needle in that angle and then gradually progress so that the chances of success are higher.
Okay. Now the next question is how to proceed when you get a bloody tap. Dr. Shilpa, you want to take the question?
Yes, sir. So when there is a bloody tap, I wouldn't inject the drug at that point of time. Depends on what kind of surgery we are having. If the tap is not continuous and there is only slight amount of blood stain, you can wait and see if it's clearing up or not. If in case it's a continuous tap, then probably you can go for another space or else, probably go for a GA in this case.
Okay. Thank you. Next question is how to proceed when the patient is previously operated for spine surgery with implant in situ. Dr. Shilpa?
The implant again depends. Probably we could take help of prior radiological images that we have to know where exactly is the implant situated and what's the surgery we are going to target and what's the level of blockade we need. Probably we could go for a space up or down if possible where the imprint is not there. Even if it's there, probably we could then again look for a paraspinous or a paramedian approach to reach the target space.
Okay, thank you. The next question from Dr. Vikram is failed spinal drill that we have already dealt. So we will move on to another question. In scoliosis or polio patient, when came for LSCS in emergency in hospital without prior information to us and not optimized or investigated for PFT or other investigations, what can be the management? This is entirely different topic.
Yes, sir. Moderator, sir, this is totally not related to this.
Yeah, this
I
is.
think we can go for other questions.
Then another question from Dr. Muthukumar Rajagopalan. He has asked what to do when the patient complains of severe pain while giving anesthesia, paresthesia. Dr. Vikram, Viral.
Yes, sir. Yes, sir. So basically, I would like to comment about this question is since we are performing mainly spinal at the level of lumbar level, whatever the shooting or a transient sensation of electrical shock-like sensation which the patient is experiencing, we are just touching the nerve, the cauda equina, the nerve roots. So we are not basically hitting the spinal cord. So if the patient complains of transient shooting pain, I just stop the procedure. I remove the needle and redirect the needle so that, and usually it does not produce permanent damage. That's what we have seen and it's there in the literature.
Okay. Thank you, Dr. Viral. Now this question is for Dr. Hamid. Benefits of additives, which should be used, which are approved. Hamid, you want to answer? What are the additives can be used?
Adding additives is it if we are having any patchy block, it will cover the area and we can add that for prolonged analgesia for the patient.
Okay. Which additives are, what are the additives approved for spinal anesthesia?
Only fentanyl has been approved.
Fentanyl. Many people are using buprenorphine also.
Yes, but it is not FDA approved.
Yeah, not FDA approved, but we are routinely using it. Okay, that comes to the end of the question answer session. And before concluding this talk, I want to give some.
Moderator, sir, another question is there: how to prepare isobaric solution regarding Taylor's method reactive? Okay, that is also a
different topic.
Different topic, yeah. Moderator can have a wind-up discussion on the slide.
Yeah, thank you very much for presenting elaborately for this topic. This is a very basic topic because spinal anesthesia is performed in 70% of our practice time. So, as I mentioned in the introduction, whatever may be the experience with us, when you don't get the spinal in the first shot, you will become a jittery. So, this topic, this presentation gave a elaborate insight into how to tackle with the difficulties in spinal anesthesia. I thank all the speakers, and there are few take-home points for the juniors while giving spinal anesthesia, because spinal anesthesia should not be taken very light. It is not an alternative to spinal anesthesia, general anesthesia. So these are the few take-home points I want to mention here. First, we should get the consent and evaluation of the patient. Explain the procedure in details, because many patients will become very apprehensive and panic when you tell them that we are going to give an injection on your back. So before the procedure, explain the procedure in details to the patients and relieve the anxiety of the patient. Discuss the possible complications. Mainly what we are worried about is post-dural puncture headache. So you explain a little bit about the post-dural puncture, and there are remedial measures available also. That also you should explain to the patient so that the patient will be assured and comfortable. Assess the patient and comorbid conditions. Mainly the airway assessment is very, very important, even though when you are giving a spinal anesthesia, because if the patient is not fit for general anesthesia, he is also not a safe patient for spinal anesthesia, because many people think that whenever the patient is having very difficult airway, we can get rid of the spinal anesthesia, but that is a wrong concept, because when there is a compromised airway, you should not give a spinal anesthesia directly without any preparation for tackling the difficult airway. So preparation is like general anesthesia, you check the OT setup completely, because you don't know when you need to convert the patient into general anesthesia. So check the OT setup like for a general anesthesia. Make sure that all the anesthesia drugs are available. Emergency drugs and equipments are available. The video laryngoscope and emergency intubating gadgets are available. Always load the vasopressors like ephedrine or phenylephrine ready, and atropine also. Keep ready before the procedure. And main thing is check the IV lines and its patterns before giving spinal anesthesia, because many people, they give the spinal anesthesia without checking the line. After that only they notice that the line is bulged and they cannot infuse the saline immediately. So in high risk patients or obese patients and in doubtful cases, always start another IV line with a large bore vent fan and make sure that that vent fan is freely flowing. That is very, very important. And check the OT table and its functions, because many times it happens the errant behavior of the OT tables can cause catastrophe, because whenever you press the remote switch, the table will misbehave. The patient may go into deep head down position. That time the level may go up and they will have a severe hypotension and bradycardia. Sometimes death has happened because of the errant behavior of the OT tables. So before giving spinal anesthesia, check the OT table and check whether it is functions properly. And before giving spinal anesthesia, talk to the patient politely and always preload the patient. Don't compromise the sterile techniques, because many people, they don't even wear the gloves. So don't compromise the sterile technique. Experienced technician is must for positioning the patient, because though you know how to give spinal anesthesia, the positioning of the patient for spinal anesthesia plays a very, very important role. So the experienced technician should be available for positioning the patient. Always administer local anesthesia before poking the spinal needle, because that gives very good comfort for the anesthetist, not only to the patient, but for the anesthetist, because we can manipulate without any discomfort to the patient. And check the drug before giving by 2 persons. On the many incidents have happened because instead of bupivacaine, they have given some other drug. So a lot of catastrophes have occurred. So avoid these complications. Before giving the drug, check the ampule twice. And once the procedure is over, our work is not over, because check the level of the block not immediately after giving the spinal anesthesia. Wait for 2 minutes. Don't keep on asking the patient about the onset of the block. That gives anxiety to the patient. Don't manipulate the table or patient position for the next 15 minutes. Give some time to for the fixation of the block. Avoid too much sedation during spinal anesthesia or epidural anesthesia because the common cause of hypoxia and respiratory arrest during spinal anesthesia is over sedation. So be vigilant about the high and total spinal anesthesia and monitor the patient regularly and be prepared to manage these complications. Maintenance, always select the spinal anesthesia for cases less than 2 hours procedures. Be vigilant during the procedure and monitor the vital signs continuously. Every 5 minutes, you should monitor the blood pressure and saturation and heart rate. At any point of time, be ready to convert to general anesthesia at the request of the surgeon or inadequate block levels, or when the patient is uncooperative, you may need to convert the patient to general anesthesia. So be prepared for general anesthesia during the spinal anesthesia procedures. And post procedures, when you are handing over the patient to the post-operative ward staff, tell them to keep the leg elevated, and pneumatic DVT pumps plays a very useful role because after the spinal anesthesia, the flaccid legs, because of the flaccid legs, the circulation is very sluggish. These patients are more prone for DVT. So always use DVT pumps till the effects wears off, and continue to monitor the vital signs and keep the vasopressors ready in the recovery area for immediate use. These are my take-home points, and thank you very much for all the speakers for giving their experience and discussing the topic. Well, now over to Dr. A.L.M. sir.
Thank you, moderator sir. This is a good take-home points we have given because they have covered sophisticated aspects of spinal anesthesia, but you have touched the basics which everyone should know. That is compulsory. So thank you very much. And I request now Dr. Hema, our treasurer, to propose vote of thanks.
Thank you, sir. Good evening, everyone. Thank you all for your participation in today's webinar on spinal anesthesia. This is our second edition in the Puthukkottai Bhudhan series.